This is a middle-aged gentleman with open angle glaucoma, a moderate open angle glaucoma, and a mild cataract, planned for a phacoemulsification and a implant, that is with the XEN gel implant. And this is how I went about performing the surgery. So initially, after putting in my incisions and under dispersive OVD creating a 5 millimeter excess, I go ahead, do my hydrodissection and do the nuclear disassembly and the emulsification. I'm going to hurry through this Phaco and take out the cortex before I implant a single piece hydrophobic lens within the back. Now, having done this is the left eye, so I've entered from the nasal side. I shift temporarily, sorry, and I'm marking with the gentian violet pen 3 millimeters apart on the surgical limbus and 3 millimeters behind. I make 2 marks just next to my phaco incision. I have to enter upper nasal. I then put in some 2 milligrams per ml mitomycin C posteriorly within the conjunctiva and push it back with a Q-tip. This will bind within a minute. Don't have to worry about it. And then I take out the pin from the injection system. This pin is just to prevent the device, the implant device, from slipping out during shipping. This is an animated picture of the whole injection system. It has a 27 gauge needle for injection. It's got the blue slider behind. And once I have taken out the pin and the stopper, I go ahead, put in some chondroitin sulfate within the chamber, and I put an agonio lens, and I am going to look at exactly where I am going to enter to the eye. I am going to enter, my entry will be just anterior to the trabecular meshwork. Don't go through the trabecular meshwork because that will cause a lot of bleeding. Just anterior, that is between the trabecular meshwork and the scleral spur. Just checking the area. And obviously this is the mirror is at lower temporal, so it is the upper nasal angle that you are watching. This is an indirect gonioscope. That was my original phaco incision. I am putting in some chondroitin sulfate and once again checking that area, and then slowly enter. This is a 1.8 millimeter incision almost, and I go across to the other nimbus. This is from the lower temporal area to the upper nasal. Put in my gonial lens. I want to do it under gonioscopic level. I want to check gonioscopically. There I have got it. Just enter anterior to the trabecular meshwork. Now we have, okay. So once you have got the mark, just enter a bit, hold on to it, and hand over the gonial lens to your assistant. Then taking, if you have a Vera hook, well and good. Otherwise, I have in this case used my sense key. Go into that port, push down and give counter traction and go intrasclerally and exit 3 millimeters behind and into the subconjunctival space where your mark is. It should be, the ideal thing is 3 millimeters behind. Don't swing your needle sidewards. Then when you are injecting, turn the needle to the side, that is 90 degrees. Do not inject with the bevel up, otherwise the implant will curl up. As you inject the slider, it goes halfway through for injection of the device, and the rest of the halfway is to retract the 27 gauge needle into the hub. So once that's retracted, you can come out. There's a little bleeding, it doesn't matter. Don't have to worry about it. And you can check with a Vexel sponge Sometimes when you inject on the subconjunctival space, there is a little heme there. Don't have to worry about it. You can tamponade if you want, if necessary, but most of the time it's not necessary. And just to check whether the implant is in place, I'm just putting some OVD on the cornea and putting my gonial lens over to check whether it has been properly placed. And you can see just next to that little bleed there is the implant, very well placed. It's about 1.5 millimeters into the antechamber, parallel to the iris, well away from the cornea. This is beautiful placement, and well, you can call it beginner's luck. So you can see that very well. Don't press too hard because you have your phaco incision as well. And then once you have checked it, you have to remove all this OVD and do that manually. Better take in a Simcoe and evacuate all your OVD from the chamber. And make sure you do a thorough job of it. I go from the incision, the phaco incision, and then to approach the area where the implant is actually placed, you go from the other side as well. And there I am going from the infratemporal paracentesis. Go right up there and aspirate all the OVD as well as if there's any hemorrhage. Just clear up everything. Just making sure I've got all the OVD out. It's these small steps that can usually cause failure of your surgery. So just do everything by the book. Finally putting in some myocul, and this is day 1 post-op. You can see that diffuse blip there. You can also see the implant and little more of a close-up on the day 1 itself. And then this is 5 months post-op, beautifully placed implant and a huge ischemic blip. Thank you very much for watching this video.